sessions began. QI Connect, as you know, provides an opportunity for colleagues across health and social care and beyond to learn from international leaders in the fields of improvement, innovation and integration. And we've designed these sessions to be short, accessible and recorded to allow access at a time that suits you. And I'm just going to welcome to the call this afternoon Jennifer Graham, who's going to take us through some of the hints and tips about using WebEx. So good afternoon, Jennifer.
Thank you, Brian, and good afternoon, everyone, and thank you for joining the session. So just a couple of quick housekeeping slides to get you started. If you could please use the chat function that you see on the right-hand side of your screen to communicate, and I'll talk you through this in just a moment. If you do have any technical difficulties, such as not being able to hear the presenter speak, or if you keep losing connection, then please message the event manager using the chat function or by pressing *0 on your telephone keypad. So these sessions are designed to be a fun, interactive learning experience, and we do encourage you to use the chat function to share any questions, comments or ideas through the talk. There will be an opportunity for Q&A at the end of the session. So if you can just click on the speech bubble icon, the chat icon that you can see circled in red there, and type your message and send. We'll also be sharing hyperlinks to any resources mentioned by our speakers today within the chat function, and we'll be sharing that afterwards. So we'd just like to get a picture of where you're actually joining us from today. So if you can just click on the pen icon that's circled in red, you can see that at the top left-hand side of your screen. And then click the arrow icon. And then click on the map where you're joining. So welcome Liz, Nick. Big shout out to David Grayson joining us from New Zealand.
Yeah, great to see everyone joining us from across Scotland and beyond. And again, welcome, David. It must be around 5 a.m. where you are in New Zealand. Welcome to all our colleagues and friends from across the world. Delighted to be able to highlight the reach of QI Connect. We've now got 472 organisations that have signed up for QI Connect, which is quite amazing. And before we go much further, let's remind ourselves of the competition here at Healthcare Improvement Scotland's QI Connect series. And it's the usual competition. We now have 49 countries joining us from across the world. And I'm going to name a country, and if the first person's arrow goes on the country flag, you win a big prize. And the country today, in homage to our friend David Grayson, is the flag of New Zealand. Rafe Roberts. Well done, Rafe, all the way from Shetland. Finger on the button, thanks very much. And David Grayson eventually gets there. Well done, David. Rafe, well done. Of course, that's the New Zealand flag. I'm grateful to you all for trying that out. And of course, Rafe, you've now got a QI Connect mug winging its way all the way up to Shetland. Rafe is the Chief Executive in NHS Shetland. So well done, Rafe. And congratulations. Now, when we started the series, as you know, we had one slide with a few wonderful logos on it, and now with QI Connect, we're reaching into 14 or 15 slides with your wonderful logos, showing from all over the world the various organisations that have signed up to QI Connect, and it's absolutely tremendous to see the reach of this quality improvement discussion. Tremendous to see people from Canada all the way through there to Singapore and to Denmark, the iHub here in Scotland, the West Midlands, and of course every part of NHS Scotland joins in with QI Connect, and wonderful to have everyone on board. And we're always especially delighted to shout out the now 43 universities where folks are joining QI Connect. We're absolutely delighted to have that connection in with the students, staff and faculty at these universities, where quality improvement across health, social care and beyond is being informed and is contributing to the QI Connect discussion. And we're absolutely delighted to shout out 4 new organisations that have joined QI Connect this month. We've got the Boston Children's Hospital in USA, we've got the Cancer Care Ontario in Canada, and we've got Implement Consulting Group, the Norwegian branch of Implement Consulting, and the Yushin Community Hospital in Singapore. You're all very, very welcome to QI Connect. And just a reminder to everyone that we record the sessions so that you can use them after this session. And this happens to be a photograph from Koawatea in New Zealand, where they told us very early doors about how they were using the recordings to listen and stimulate some conversation there around quality improvement. And all of the recordings over the past 3 years are now freely and easily available on our Healthcare Improvement Scotland website. So looking forward to you using them in future. And we're of course always delighted to give a big shout out to our friends at the International Society for Quality in Healthcare. That's the ISQA organisation, where the fellowship programme uses the QI Connect series as an approved resource within the fellowship there. And a shout out also to our small but perfectly formed QI Connect team. You've heard from Jennifer already on the call. We're joined by Ross Stewart, who does all the administration and certification, and will be in touch with the recording after the event. And of course our wonderful Twitter analytics from Alex Sterling. Absolutely wonderful to have the team together working on your behalf with QI Connect. And joining the team today, and you'll hear from Nick later in the call, is Nick Kenton, who's the Director of Finance at NHS Highlands here in Scotland. And I look forward to introducing Nick later in the call. And of course, remember, please tweet as you learn, hashtag HISQIConnect, and follow us at HISQIConnect. We have a great following, and it allows a great sharing of resources and comments and commentary on quality improvement. Delighted to have you join us. And that leaves it for me to welcome our speaker today. Our QI Connect speaker today has been Chief Executive and President of Bellin Health for almost 25 years. George Kerwin is a Fellow of the American College of Healthcare Executives, a Board Member of the Green Bay Packers NFL team, and Chairman of the Board of About Health, a clinically integrated network of health systems which serves populations throughout Wisconsin and the Upper Peninsula of Michigan and portions of Minnesota and Iowa. Bellin was an original member of the Quality Management Network and is currently a very active member in the Institute of Healthcare Improvement Leadership Alliance. And it's my absolute pleasure to welcome George to the call today. Good afternoon, George.
Well, good afternoon, Brian, and hello, everyone. It's great to be with you and to share our work here at Bellin. I have limited time, and I have a lot to talk about. So I want to just get going and give you, first of all, a little bit of background. I want to indicate where it is that we are in, excuse me here. So we're located in the Midwest of the United States, Upper Midwest. It's an interesting part of the country, very stable, high productivity. Bellin itself serves a market in the northeastern part of that state, and we extend ourselves into the UP, the Upper Peninsula of Michigan. Within this market, we are a clinically integrated organization with assets that include an acute care hospital, a critical access hospital, which in the U.S. is a smaller hospital with limited beds and functionality. We are integrated with our primary care physicians. We extend primary care throughout this region. And and include in that primary care base locations in employer settings and in retail settings. We have pulled together really all of the components of the delivery system that include primary care, hospitals, specialty care, behavioral health is part of our organization with a very vibrant offering in psychiatry, and we have a very well-established palliative and hospice care part of the organization. So this is the extent of the organization. We serve a population of 640,000 people. There are 2 other integrated systems similar to ours in the region, so the 3 systems serve that size of the population. You can see the map, and one thing I want to emphasize is that we have a very well-balanced delivery system with all these components, spread out primary care, very condensed and highly functional specialty care, covering really all disciplines of a tertiary integrated system. I wanted to talk today about our work in managing the health of the population that we serve. And there are different ways of presenting this information. One way that I found very helpful is by using the IHI High Impact Leadership Model, which we shared with you before the call. It's just a very good way of thinking about any issue that you're trying to manage within your organization. In this case, I'm going to use the leadership model to trace our work toward managing the health of the people in this market. You have to understand that Bellin is a pretty typical integrated system in the U.S. We are moderate in size, so we're not a great big huge system that covers multiple states. Very moderate, very condensed within a specific population. And then I want to share this with you in a way that would allow you to evaluate your specific organizations wherever you are in this journey, and maybe define how you can improve your ability to manage the health of the people that you serve. So those are the objectives of the session. So to start with, I want to just spend a minute on talking about the High Impact Leadership Framework. It's a framework designed by the Institute for Healthcare Improvement. It pulls together concepts that we need to consider as we're leading our organizations in the healthcare delivery area. First and foremost, we have to be driven by people and by the communities that we serve. We have to be focused in on the population that we serve. Know it, define it, understand that population. Within our organizations, and we have some 5,000 people within our delivery system of all different backgrounds, we have to create a vision and build will within the workforce, within our organizations. We have to do things differently. We're dealing with a difference in terms of the flow of dollars. We're dealing with differences in people's responsibilities. So we have to do a great job in leading these organizations in helping everyone understand where it is we're going and building will to go in that direction. We have to develop the capability. And this is an area of the model where a lot of time is devoted and a lot of resources. For us, what I've described is an organization that has over 25 years put together a very high-functioning delivery system with complete capability of managing the health of our population. Developing that capability includes certainly people, it includes bricks and mortar, it includes technology, it especially includes information technology, and I'm going to touch on that. So those are all the elements that we need to manage populations. I would say the other thing in terms of our capability building and certainly your capability building is taking inventory of the capability that exists outside of our organizations that can be very directed at helping us manage the health of populations. And I'll touch on that in the presentation. The next area is delivering results. If we're driven by people, we have a vision as to what we want to do, we feel we've got the capability, we need to deliver results. And in terms of delivering healthcare services, especially in the U.S., when we talk about delivering results, we're talking about results in the area of the cost of care, of the level of health within a population, and the experience and the knowledge that the population has. Those are the areas that we focus on, very triple aim-oriented results categories that we're very focused on. Also, in our organization, we spend time on the culture internally. The culture, making sure that people get along, that they know their roles and responsibilities, that they're able to work in teams effectively. That's a critical part of our leadership. And then lastly, and I've mentioned this in terms of developing capability, we have to understand that we need to be able to engage across boundaries. We're not just delivering healthcare services in an acute care hospital or in a primary care clinic. We have to engage ourselves. We have to go outside of those boundaries, those traditional boundaries, in order to really have an impact on the determinants of health within our population. Well, that's the model, and I'm going to go through that model really area by area and paint a little bit clearer picture around managing the health of populations. The first area I'm going to focus on is being driven by persons and the communities that we serve. And this is a visual of a sense in our organization. And I would say that the understanding of this pervades the organization, that people within the organization, all over the organization, understand this. And this is a simple reality that all of us, all of these people in this market, all of us, have a life cycle. We're all born, we all grow, learn, become productive citizens, have families, we all grow old, and we eventually all die. That is our life cycle. And our work in managing the health of populations is to overlay a health cycle on that exact life cycle, on bringing people into the world in a very healthy way, which we do a very good job of, in helping children grow and be nourished by their families and receive the appropriate care at a young age. We want to overlay this health cycle in the middle part of our lives. We want the population to understand the importance of prevention, of lifestyle. We want people to understand as they grow a little bit older the importance of screening and certainly of managing any kind of chronic conditions that they might have, all in an effort to avoid very expensive acute care crises at a point in the life where that shouldn't occur, where we can manage the health of that population. Ultimately, that health cycle leads us to the aging process. And really, ultimately, it leads us to palliative and hospice care and the ability to die in a very dignified way and in a way that is consistent with a good life. We understand this within Bellin. We all should understand this when it comes to managing the health of populations. This overlay of a health cycle on a life cycle is within our capability. This is our market. Geographically, these are some of the people in our market. I talked about the locations of our delivery system. What I want to emphasize here is in understanding this population and the people, being able to segment this population is critical. Segmenting the population around a variety of issues. One issue for us that's important is where people receive their health benefit. In the U.S., people receive their health benefit from an employer. They might receive it from the state in terms of Medicaid. They might receive it from the federal government. In the case of Medicare, they might be uninsured. They might have no insurance at all. But that's one way of segmenting our population. And for us, it's very helpful because in our population, over half of the population, 55% of the population, receives a health benefit through an employer. And that's a critical condition, a critical characteristic that we have, because if we want to engage this population as a whole, we can segment the population, over half of it, by focusing on employers and reaching the population through the employer. Another important factor is understanding the Medicare population. How many people are insured by that source of payment, knowing where they are. Segmenting the population around chronic conditions, around disabilities. 25,000 people in this population are disabled, and that's important for us to know. So the ability to segment the population is critical. Those are two critical areas in that first dimension of the model. Well then, creating vision and building will. And in this area, what I wanted to share with you is our mission statement, our vision statement. So we are an organization that is community-owned, we're not-for-profit, and we are responsible for improving the health and well-being of the people living in northeastern Wisconsin and that Upper Peninsula, and all others we serve, that specific market. We carry out this responsibility through the care that we offer, and we offer care, just incredible care, in the acute care setting, in primary care, keeping people in our panel that we're directly caring for under very excellent care. We carry out this mission through community health improvement, getting outside of our boundaries, working in employers, working in school districts, getting out and engaging different segments of the population in the most effective way possible. Wherever we can leverage our resource with another resource in this community, that's what we need to do to follow this part of our mission. And then thirdly, we carry this out by offering equitable health financing plans, making sure that people in this population have insurance coverage of one kind or the other, or if they don't have any coverage, that we help them through whatever issues they're dealing with in an equitable way, irrespective of their ability to pay. We're steadfast in our commitment to providing compassionate, safe, and coordinated care. Very important is that it's accessible, and very important that it's affordable. We build trusted relationships within this market. People know us, they trust us, they collaborate with us, and we learn so much from the relationships that we have that really fuels our desire to improve and to innovate. And ultimately, our vision is that the people in this region will be the healthiest in the nation. We measure that. We measure improvement in that area of the entire health of the population, and we want that to result in improved economic vitality in the communities that we serve. So mission statement, vision statement, and then ways of creating the characteristics of the organization that will allow us to be successful. We concentrate on including patients, families, and customers in our organization. We work hard internally to build teams and to create a very positive culture. We work, as I mentioned, and I will describe, on improving the health of the population. And lastly, we want to grow and we want to be sustainable, but we want that to occur while the population is spending the lowest cost of care in the nation. So those are the areas that we focus on, that we establish a vision. Here's where we want to go with this work and build will. We talk about these concepts over and over again. Developing the capability. I've described the organization, the makeup of the organization, the components that we have. This organization comes together in an integrated way. We have primary care, specialty care, acute care services, behavioral health, hospice services. I showed you the map that depicts where that is and how that is put together. Very integrated, very high functioning, people that get along, that know where they're going. But really, to manage the health of populations, there's a new system, and it's outside of our walls. It's much broader. It includes many other factors that exist. It includes the entire population. It includes the resources that are in the community. We have to make sure that people have great access to healthcare services. We have to make sure that aftercare, where they go beyond the acute care episode or primary care, that they have care available to them. Families and community resources, which encompasses the broad spectrum of all the determinants of health, police departments, boys and girls clubs, schools, I mean the vast resources that are available in any population. So this is, in our view, this is a picture of all the makeup of the integrated system. It isn't just the delivery system. It's really all-encompassing all of the determinants of health and the organizations and people that represent those in our communities. So this new integrated system we view as our set of resources, our capability in a sense, to manage populations, and we view the management of the health of populations as the panels of people and the employees where we have very direct relationships. And then we distinguish the management, the direct management of the health of a population from the overall health of the entire population. And when we're addressing that issue, we're dealing with different resources, different objectives. We're trying to impact segments of the population, and we're trying to influence the community, the members of the community as a whole. Here we have our hands around this percentage of the population. Here we are trying to influence maybe people that are going to other health systems, people that aren't using health care at all. So this is part of the capability that we feel we need to have, the type of the integrated system, and then ultimately there are resources that are just incredible that are being made available to us really as we speak, literally. This is an overview of, it comes from Epic, the software that we use within our integrated system, and everyone in our system is on Epic, so it's enterprise-wide here in our organization. This is an area of their software called Healthy Planet. And you have this so you can take a look at it in detail. But this is a snapshot of the capability of software, the current capability of software. It's new for us, and the capability that will allow us to manage the health of these populations. And just look at the headers. The ability to bring outside data, payment data, into our management of the health of populations. No longer guessing at the cost of care, at the cost of the individual, at whether they're using healthcare in a resourceful way. They have capability to bring in multi-organizational information. We're one system. There are 2 other systems in this community. There are dozens of systems in the state. This software allows us to look at a population, to look at a person irrespective of the health system and the software that they're being cared by. The software helps us to predict and stratify the population that we're serving. We use this very effectively in employers to be able to stratify the health of that employed population to identify how to help manage that population. We can compare our work with other organizations. We can control our costs and maximize the gains by looking at more efficient ways of spending our dollars, avoiding expensive care, directing people at more efficient care. This software gives us care management tools, gives us wellness and preventative tools, allows us to engage with our patients, to communicate with our patients, to allow patients easy access to our care, making an appointment with a clinician, doing an e-visit with a clinician. Very powerful in managing the health of populations. This software allows us to investigate populations and patients and really allows us to connect with external groups. High functionality, you have the slide, there's more detail to it. This software is new, it exists, we are using it, not all these features, but we are doing our work with the assistance of this type of software, and everyone around the world should be just chomping at the bit to be able to get their hands on this type of functionality, building capability. The last thing I want to talk about in this category of developing capability is we follow a 9-step process to manage the health of populations. We've sent this to you in great detail, so I'm not going to go through it. I'm going to skim through it. This is a 9-step process. It's very rigorous for us. We apply this process to any population that we're managing. Medicare population of elderly people, population of employees, children, you name it, we use this 9-step process. Understanding the population, defining the goals for the population, designing care for this specific population, activating and informing the care team as to what we're managing here, the types of people that we're managing, looking at engaging the people in their own health, making sure that they know how to access care, that they know how to help manage their own care. We want to be able to measure outcomes and then get into a PDSA loop, providing feedback, looking for our results, and then going right back to the beginning of the process and recalibrating our goals. This you have in great detail, and I would encourage you to take a look at it. It's part of our capability. Then, given all that, and that's a lot, we need to deliver results. We need to be able to deliver results in areas that are critical, in areas that relate to cost, relate to the health of a population or the health of an individual, results that relate to the overall experience of care, the ability to gain access, et cetera. So want to talk about results in a few different populations, segments, if you will, of our entire population. And the first area I want to just describe real briefly, real high level, is us. We have a population. We insure 5,000 people and their dependents. We want to manage the health of that population first and foremost to be a model for the other segments within our market. We apply that 9-step process. We apply that capability that I just described, and we have been very effective in managing the health of our population. We've been effective in terms of cost, keeping the average increase at a very reasonable level and significantly below the average for our employers. We have cost trend going back 15 years. We manage this. This is a high-level description of our work. We can drill down to the individual. We have, obviously, to accomplish this, done a great job in managing the health of our population. In our case, with these insured lives, we actually, in a detailed way, manage the health of this population through health risk appraisals, very clinically oriented, and we've had improvement in our overall scores commensurate with the improvement in our overall cost. And overall for us, literally this has saved us $4 million a year over year, and these are real dollars for us. These aren't estimates. These are dollars that we can use for other purposes within our organization, one of which is to keep our overall costs down. So we've taken that experience and taken it out to other segments, other employers in our market, and have had significant benefit for those, and delivered results in a very positive way for those employers. And we engage with employers at different levels, really from very brief interactions with employers in that first area to installing occupational health types of offerings within an employer, to actually having clinics with RNs, physicians, physician assistants on site, to ultimately having a strategic partnership with employers where we actually share the overall risk of managing that health with the employer. So we have different levels of engagement, but as you can imagine, we engage with really hundreds and hundreds of employers throughout our region. The strategic partner group is limited in number. There are 16 of them. It's a pretty good percentage of the population, 26,000 employees and dependents. We've delivered results for them, keeping their increase very well managed in terms of cost, helping them improve their health risk appraisals over time, which is very consistent with the improvements in overall cost. Here's an example of one of our strategic partners. Happens to be the county. The county as an employer. The county, you can see, has 3,500 people that they're responsible for in their health plan. In our county, and there are 72 counties in the state of Wisconsin, they've averaged actually a 3.3% decrease in their overall spend these last 4 years. Their overall spend per employee plan per year, it's a metric that we use in the U.S., so their overall spend is $10,800 per employee plan. The average for the other 71 counties is $14,400. Done in the same way, the 9-step process, concentrated in this case also on health risk appraisals, very positive performance there. And in the case of the county, almost $5 million in savings. And if you know county government and government in general, those are tax dollars. That allows our county to keep the overall property tax rate under control. Critical strategic partner for us, and as you can imagine, delivering results for them gets a lot of attention. Another area in which we are delivering results is for the federal government. We participated in an initiative, Test of Change, that came from CMS, the Center for Medicaid and Medicare Services, which is really the large bureaucracy in the federal government that manages the health of the Medicare population. In this Test of Change, we managed 20,000 lives, again, a large percentage of our overall population, for 3 years. And the health costs over that 3-year period on average, and it was pretty consistent the whole 3 years, came down actually a little bit, $8,500 a year per person. Now this is per person. It was the lowest of 33 pioneers, the lowest cost of the 33 pioneers that were selected by the federal government for these tests of change. And these other pioneers were in different parts of the country, larger organizations certainly than ours, lowest cost. In this test of change, the government had quality metrics that some 3 or 4 dozen quality metrics that we had to measure and improve on. Our overall score was, as you can see, 94.5%. That score was the highest of all pioneers. So we're talking about delivering results here, and we're talking about our biggest payer, an organization that is in crisis, that is very high profile, and we delivered results. We saved the federal government $13.6 million, and they actually shared $9.5 million with us in real dollars back to us. So delivering results in different segments of the population, different examples, all with different demographics, et cetera, using the same approach, the same delivery system, the same set of capabilities. Delivering results like this is good for the entities that we're serving, good for the people that we're caring for, but very motivating for us in developing will, building will, and reinforcing that this is the right direction to go. So I want to touch on shaping the culture. I mentioned that that's important to us. We have a very organized way of looking at our culture. We measure our culture in these ways: retention. We measure the health and the safety of our employees. We measure the degree of engagement and the performance. Everyone in the organization knows what they need to do to perform, and we measure these 4 areas. We feel that the areas that we influence as an employer are right here, and I'm not going to go through them in detail, but they go way beyond wages and benefits. They touch on things like leadership, like improvement knowledge, understanding quality improvement theory. We talk about understanding these concepts and our strategies, what we're trying to accomplish. They talk about our recruitment process and acclimating people to the organization, evaluating them, and a positive culture is one where the people in the organization understand that this place is sustainable for the future. We're delivering results. It doesn't get much better than this. To be responsible for the health, both physical and mental health of this population, having influence on them, working together, and having this type of result, we're sustainable. That's huge when it comes to culture. And then lastly, just want to mention, and I've mentioned it through the presentation, the importance of engaging across boundaries. We all know that there are a lot of different determinants of health, a lot of influences on health. This is our depiction of the determinants. We understand this. We understand the county health rankings, which is not as colorful a depiction of the determinants of health. We know that for us, all that capability on our own, that delivery system, it sits right down here. But the new delivery system, what we really need to capture is all of these resources that are here, the employers, the police departments, the schools, the areas that make food for us, government, all the areas that influence our social networking, emphasizing the importance of good behavior, good habits, and trying to help to stem, the tide against bad habits that will get in the way of our health. This is, in a sense, the new delivery system depicted around the determinants of health. Well, that's the model. I think you can understand, driven by our understanding of people and the communities that we serve, understanding how to overlay our health plans and our health capability on a life cycle, that health cycle, creating vision and building will and reinforcing that vision and will by the results that we deliver, building capability and embracing all the capability that is on the horizon that we're about to be able to access across the world, having very, very good results, and they don't come easily, but having a very disciplined way of managing the health of a given segment, having positive culture. We can't do this work if we don't get along. We can't do this work if we're squabbling between each other. This takes a lot of effort, and a lot of effort can be sucked away in a bad culture. And then viewing all of the assets in this community as assets that are to be partnered with us in doing our work. So I'll end there. I hope I didn't go too fast. As I said, I gave you some additional resources that will be helpful, I think, and would welcome questions that you have.
George, that was absolutely tremendous. Thank you so much. And the chat box has been alive with commentary and comments and questions, and I'll put some of those to you in a moment. But let's welcome into the call Nick Kenton, the Director of Finance at NHS Highland. Good afternoon, Nick. And you might be on mute, which is *6 to get you back off there. And George, just while we're getting Nick on the call, a number of comments. Akin Akinola, who's a specialty doctor for quality improvement at the Golden Jubilee, and he runs the Improvement Club there. That's a large specialist hospital here in Scotland. He said he really enjoyed the presentation. It was super to see how the data was being used to understand health needs, population needs, and person-centered care, all the way through to cost effectiveness. So he was seeing a lot of synergy in what you were saying. Nick, are you with us now?
Can you hear me now?
Yes, I can. Good afternoon, Nick, and welcome to the call.
Good afternoon, and thanks very much for the presentation, George. Really fascinating. Shall I fire away with my question now, Brian?
Yeah, that would be super, Nick. Thanks.
Okay. Is it possible to go to the slide 45, just because that sort of is the slide I want to particularly ask about? because George, in your presentation, you talked quite a bit about integration, which is a real theme here in Scotland at the moment. And it's just the next step, if you just advance it to get the, that's right, where you have the whole system in place. And as you rightly say, healthcare is in the context of a whole system, but I didn't really hear you talk much about social care. That was mentioned towards the end in the determinants of healthcare slide. So I just wondered how social care fits into that equation, and whether it's to what extent it's within the blue box, or to what extent it's within the system of production, within the box in the middle.
Yeah, it's definitely, as I mentioned in the last slide relating to this, it is critical to our thinking, and we get involved in many agencies in the community that deal with those aspects of a person's life. In terms of this depiction, it could be identified more specifically, but it's over on the right-hand side where we identify the importance of families and community resources. And the community resources is a term that would be inclusive of all the resources in a community. And there are, at least in the U.S., and I can imagine in around the world, but in the U.S., in any community, there are unbelievable community resources, agencies, organizations that are designed to help the social aspects of a person's life. And we formally connect with those organizations. Most of the time when we do, we are not the lead in terms of working with them. We are at the table with them to help them, to lend our voice to the work that they're doing. So it's a critical part of our view of managing, especially the population of the community as a whole.
Okay, thank you.
Thank you.
Thank you very much for that, George. And Nick, you also had, just in the chat box, you were asking some questions. We're limited here in the UK and certainly in Scotland in terms of having activity data and cost data. Was there anything that struck you in what George was saying in terms of a vision for Scotland?
Well, I mean, clearly Bellin have got a very good access to information. That's something we really lack in the UK, and I guess that's one of the benefits of being in a system where there's more transactions involved in the healthcare system that does give you that information. So I think we are limited if we're trying to sort of stratify populations. That does hamper us. So for me, I think we need to invest more in information and costing systems.
Yeah, Nick, I would want to emphasize that the issue of access to information. Obviously, that slide I showed you about Healthy Planet, that capability, the capability of integrating clinical data with cost data is made possible by software. We're doing that now, and it's invaluable. It's invaluable to really, if our role is to help to manage the cost of care for a population, and it is, we need to know what that is. We need to know what that is. We need to be able to relate the cost of care down to the individual and combine the view in a way that right there in the front line, we know what the cost is for the individual. We know what care they're receiving or not receiving. When you can combine those metrics, it is a picture that if you haven't had that, you will just be in awe. It's one of those moments when I know this has existed. I've never seen it. Let me add it, and it is very actionable. A very actionable and very impactful picture that we need to push for around the world.
Thank you very much for that, George, and thanks for your questions, Nick. We've got a question here, George, from Ingrid Alexander, who's an Improvement Programme Manager in NHS Fife here in Scotland. Ingrid was very much applauding the development of leaders in your system and the folks that work in your system in terms of quality improvement. But her question that she's asking is around culture, and she says, how do we ensure that we promote a positive quality improvement culture against a backdrop of performance management and efficiency savings? How do you keep that culture focused on quality improvement?
Well, I guess we make the connection. We don't hide from the importance of being efficient, whatever, lowering our overall expenditures, staying within a budget. Those are all important to us. But we make the connection between improvement theory and cost. In other words, we don't pursue tests of change or improvement that are ethereal or that are things that are nice to have, or boy, look at what we did, without including, look at what we did and look at the positive impact that has had on our cost structure. So we consciously make that connection. And the other thing I would say is in our organization, the financial area, the chief financial officer, the accounting department, they are critical supporters of improvement, and we bring them in right at the point of hiring. In other words, if they're a critical ally and they have to be on board and encouraging the adoption of improvement theory, understanding the impact, the positive impact that has on the cost structure.
Yeah, and that goes very much to Akina Canola's point that he's made in the chat box, which was around, do you invest in developing QI skills at leadership and staff level? And clearly you do.
Yes.
Yeah, great. Now listen, Jennifer, sorry, George, carry on.
Yeah. I would just say we do that in a number of ways. We do it formally. We work very closely with IHI over the years. We are part of the IHI Open School, and then I would say that, as you can sense, the improvement theory is really embedded in our work, so you can almost, as a leader, learn a lot just from osmosis around here. But we do have formal ways of training leaders in improvement theory.
Great, thanks, George. We've got time for two quick final questions, I think. So one from our very own Jennifer Graham here, Clinical Program Manager here at Healthcare Improvement Scotland. You mentioned the fast care clinics, and was a cultural shift required in terms of developing the fast care clinics, and were people content to move from accessing care within hospitals to retail-based clinics?
Yeah, there were obstacles to that from clinicians. Fast care clinics are staffed by advanced practice clinicians, nurse practitioners. They're in the retail setting. There's a very limited, specific menu of care that can be provided. And when it was initially proposed, the primary care base felt that that was going to take away the less acute visits that they would be able to experience and enjoy the benefits of that. The argument that we used is this is care that isn't coming to you. This will increase your panel. This will be a place for you to send patients to after hours, et cetera. We got it going, and that was the result that we experienced. It didn't decrease anyone's panel. It increased our volume for obvious reasons.
Yeah, great, George. And just one final quick point from Nick again, Nick Kenton. Do you aim to shift expenditure from acute services upstream into primary care? Is that your aim?
Yeah, it definitely is our aim, and we see it over and over in different areas. 15 years ago, we did 800 open heart procedures here in our hospital. Last year, we did 250. That work is pushed to the cath lab in much less invasive procedures. We work very hard to maintain positive health in people that have chronic conditions, keep them out of the hospital. We do that as an integrated system. We don't worry about what we're losing on the acute side. Certainly that puts cost pressure on us, but we have to manage that. We need to be able to manage the decrease in those open heart procedures, and we've been effective at doing that. You have to remember that this change occurs over time. It's not an abrupt overnight, all of a sudden we're out all kinds of revenue that we had enjoyed maybe the month before. This happens over time, but we have to be vigilant in consciously shifting away from dependence on acute care to dependence actually on primary care.
Thank you very much for that, George, and thanks to the other questioners and comments. Michelle Gillis, the clinical lecturer at University of Glasgow. Thanks for your comments, George. We wish you all the very best in the changes that are happening in the US. We've been very impressed with what you've described for us today. It's really resonated, and we look forward to hearing how QI connectors find once they get a chance to take a look at the playbook following this call. So, George, thank you very much for sharing your learning, and as part of our QI Connect series. And folks, you'll see now that we're coming to the end of a wonderful year of QI Connect, and we have Tim Brown, the Chief Executive of IDEO, one of the world's top design and innovation agencies, joining us on the 22nd of November. Now, this is going to be a really special session, folks. We're going to have input from design schools across Scotland. We're going to have an amazing panel, and Tim's going to be on that panel with us, so a different format for QI Connect, and as you can see, a slightly different time, perhaps to make it easier for our friends in New Zealand to join us. Thank you all very much, and Shelley from BT, thank you for your help today as well. Thank you, and good night. Okay.